Alright, now we are about to discuss the pancreatic cyst. First of all, relax, don't panic when you look at this table. We will go through it, make it simple and easy to memorize. First I want you to know that the pancreatic cysts are not uncommon. Actually, this is the board point, and it's do exist in up to 14% of the general population. Okay, we have four main types that we need to focus on. The serous cystadenomas, the mucinous cystadenomas, the IPMNs, which is a mucinous type, and the pseudopapillary cystic tumor. Regarding the epidemiology, the idea here when we talk about the pancreatic cysts is you need to pick the specific features, the clues that will help you to reach the diagnosis. Then from that point you can start giving the right management. First of all, the pancreatic cysts, most of them do have a malignant potential, except the serous cystadenomas, and of course the pseudocyst, which was put here for the purpose of comparison. So most of them do have malignant potential, but the serous type does not. The other thing I want you to know that the serous type is the commonest benign type among the cysts, with the branched duct. The IPMN type is the commonest ever. Okay, so the first clue you're gonna look for is the location of the cyst. Let me give you some mnemonic that will help you start collecting the data regarding these cysts. Serous, let's make a little change on that and make it serious. So someone is serious should be on old age. So a serious female would be 70 years old, while mucinous, the mucin is a kind of a loose material. So I expect that a 50-year-old will be much loose than a 70-year-old. So let's keep this in mind: 70 serious, 50 mucinous. The other thing when we talk about the location now is the serious people usually use their heads, alright, and the loose people, they use their tails and bodies. Also, the IPMN is a serious disease, so usually it's in the head more than the tail. So serous head, mucinous tail and body, IPMN head. That's easy now. Now we know that serous is the commonest benign, the branched duct is the commonest other type, or the one among the ones that have malignant potential. Okay. Now we discuss the gender difference, the epidemiology, and the location, and the age. The thing that you want to keep in mind here, that the pseudopapillary cyst tumor is a disease of the young females. Usually they are 35 or less. Okay, let's move to the etiology now. There is 2 points, and one of them is a board point, that the serous cystadenoma is related to the von Haber-Lindo disease, while the IPMN is a KRAS related. Regarding the etiology, which will help you find out about the symptomatology. Usually these cysts are either asymptomatic or have a mass effect due to the size, except the IPMN, which the mucin plays a major role in the disease development. Actually, the mucin become thick with time, and it does clogs the pancreatic duct system and leads to recurrent pancreatitis. So the IBMN usually present with recurrent pancreatitis rather than a mass. The other thing about the IBMN that you have to keep in mind that is there are three types of it: a branch duct and a mixed or combined type, branch and main duct, and only main duct type. The main duct type, main intestinal, they have intestinal cells. With the branch duct have a gastric cell type, the stomach is in the belly, of course, so that might help you remember that. And why does it carry a more malignant potential, the main duct? Because the intestinal type are prone to have more dysplastic changes. Alright. So before we go to the diagnosis and the management, let's keep this in mind. If you find any pancreatic cyst on ultrasound that is asymptomatic, less than 1 centimeter, and a main duct which is normal less than 5 millimeters, you don't need to do any further workup. Just observe that patient and bring him or bring her for CT or MRCP every 2 to 3 years. And if this shows a stable disease, you just observe these patients. Alright. Regarding diagnosis now. Actually, these are the features we're going to discuss here are the MRCP image findings that you might get some clues to know which is which cyst you're looking for. So when we order the MRCP, if you have a cyst that is not less than 1 centimeter, which is above, you mean 1 to 2 centimeter, or there is a dilatation of the main pancreatic duct, or if the patient is symptomatic, you first do an MRCP and keep in mind that you will definitely at some point need an EUS with the FNA to look for the rest of the clues. So regarding the cysts, all these type of cysts are usually located in one focus, except the IBMN, which is a multifocal disease. The other thing, when we talk in more details, the serous cysts are a one focus of a cluster of multilocular, usually small rather than large cysts, that is 1 to 2 millimeters. You're gonna find in the question or the clues that you're talking these trigger words: septa, sunburst sign, honeycomb, a central scar, which is a central calcifications. So if you see these words, that mean that they're talking about the serous cyst. When we move to the mucinous cyst, which are usually one focus, unilocular, they are larger cysts, and they are mean that they are more than 2 centimeters. They have ovarian type stroma, when they describe it, they said a cyst over a cyst, sharing common capsule, and they appear like an orange-like. When we move to the IPMN, they are multifocal. They usually are large, and they are grape-like. Grape-like because they occupy multi locations, and they are cystic, so they look like a bunch of grapes. The pseudocystic tumor, usually this tumor is very characteristic and unique. It has a thick rim, calcification, and there are multiple solid dents with hemorrhagic small cysts inside, so they look like a complex cyst. Now, when you know these characteristic features of the cyst, you need to look now at the main pancreatic duct. The only type that you will find a dilated main pancreatic duct is the mixed or the main duct IBMN type. Usually they are more than 5 millimeters. The rest of the types, they don't lead to a dilated main pancreatic duct. The last feature regarding the imaging here is the duct-cyst communication. None of the types leads to communication between the cyst and the main pancreatic duct, except the pseudocyst and the IPMN. IPMN always have this feature, communication between the main duct and the cysts. One other hint that you might come across is that when you do an ERCP and you find the ampulla with this characteristic fish mouth, a wide open papilla, this is definitely an main duct or mixed type IBMN. Okay, once you need to do the EUS and the FNA to differentially diagnose between the cysts. What concerns you here is the CEA level. CEA doesn't mean malignancy. CEA means that there's a high mucin content in this cyst. The only two types that have this high level of CEA more than 192 are the mucinous and the IPMN, because both of them produce mucin. Don't need to focus much about the other features of the amylase and the CA19-9. One other thing you might come across is that the nature of the cells and the content of the cyst. Once they tell you that the cytology of the cyst shows a cuboidal epithelium that stains glycogen, that's definitely a serous cyst. One other thing is that the mucin producing types, they do have high mucin and a thick, sticky secretions. Also the KRAS we said at the beginning, and the IBMN, interleukin-1 beta also is one characteristic feature of the IBMN. Regarding the management now, usually the pseudocyst doesn't need any treatment unless it's symptomatic. Forget about the size now doesn't matter at all. So once you have complicated cyst, you go ahead and drain it. If it doesn't work, you refer the patient for surgery. The serous cyst, you don't need to do anything if there is no symptoms. Just observe the patient, and you don't need to do any follow-up imaging. Once it's become symptomatic, you send the patient for surgery. Same thing for the mucinous cyst adenoma. This is the opposite type of management. If the patient was found to have a mucinous cyst adenoma, you always send that patient for surgery. You don't wait for symptoms. And once you do the surgery, you don't need to follow with any imaging. Regarding the IPMN, it's two types, the branch duct and the main duct, with the pancreatic duct, which is the mixed type, or the main pancreatic duct. The main pancreatic duct and the branch duct mixed type, you always send these patients for surgery. You treat them like the mucinous type cells. The issue now here, the headache, is with the pancreatic duct type. We will discuss it in the next video. The pseudocystic tumor, once you diagnose it, because we said it has a high malignant potential, you always send them for surgery. So again, quickly, only symptomatic pseudocyst and the serous cyst, you send them for surgery. You don't need to follow them later on. Mucinous and main pancreatic duct and pseudocystic tumor, you always send those patients for surgery. Hope that helps.